treatment, the problem of the treatment is that the younger child is fretful and difficult to examine fully. Worried parents and crying child causes a problem. Many fractures are difficult to see, and there is a need of the X-ray of a good quality. Then it requires general anesthesia for the manipulation, and circulatory compromise is relatively common. This redisplacement after reduction is more common during the first week, and wound care should be the same as in adults. Overgrowth along the long bone fracture is very common problem, and an overlap about 1 centimeter should be allowed. So, points remember are to be that the general rules in the treatment of fracture in children, that is angulation is more than 10 degree is unacceptable. Rotation will not be compensated and hence is not acceptable. Overlap of fracture site by 1 to 2 centimeter is acceptable as there is overgrowth following a long bone fracture, and correction occur at the average rate of 1% per month. Next is a conservative treatment. Conservative methods include that masterly inactivity, NSAIDs, crepe bandage, sling, etc. for undisplaced fractures, and step-by-step conservative treatment, that is close reduction and casting, and green stick bend method for forearm bone fracture. That is, this is a diagram of the green stick fracture, and this is the X-ray of a child which shows the green stick fracture of forearm. Then next is a close reduction. So if the bone are bent and one cortex is broken, and then close reduction under GA, that is general anesthesia, and the breaking of the other cortex is done, this is followed by plaster cast application. And if the other cortex is not broken, then there are chances of malunion due to the differential growth of the one cortex. Close reduction and manipulation shows that this is preferred if the fracture is displaced and is done under GA in major OT, and retention is usually by the slab, cast, and rarely by the fraction. So, for the close reduction, if the bone is bent, there is only bending of the bone, that is, one cortex is broken but other is not, then close reduction, that is, CD is done under GA, that is, close reduction under general anesthesia, and breaking the other cortex is done. And this is followed by the plaster cast application. So, after the close reduction, plaster cast application is important. And if the other cortex is not broken, then there are chances of the malunion due to the differential growth of the cortex. Then